Hi, this is Katrina Wu, and today we'll be talking about the bony pelvis. I would recommend watching this lecture after you've had a chance to do the readings. This lecture isn't intended to be comprehensive so much as summarize and touch on all the primary key points for this week. So we'll talk about pelvis types, mechanisms of labor, fetal presentations and head dimensions, fetal position, and station. So really the goals for this week are that you would feel comfortable with the bony pelvis and the bony pelvis landmarks, as well as have a good sense of how the fetus would navigate through the pelvis in labor. So let's start by taking a look at this pelvis. Can you identify where the sacrum is? Do you see the coccyx? What three bones comprise the pelvis itself? Can you find them and label them? What three areas give the pelvis mobility during labor? Progesterone and relaxin help to soften cartilage that can expand the pelvis even up to 2 centimeters in labor. Can you see where those three areas are that help to give more flexibility in labor? It's just barely visible in this image, but can you see the bony landmark we're looking to be able to determine station so we can see how the fetal head is descending during labor? What is that bony landmark, and can you find it? Can you identify the top of the pubic symphysis? That'll be our landmark for when we're measuring fetal growth in prenatal visits. How about if you were wanting to measure a diagonal conjugate? Do you remember where your fingers need to go to be able to determine that? Can you find the ischial tuberosities? If you haven't had a chance to watch the pelvimetry video as well as done the readings, you may want to return back to this lecture after you've done those and just check for yourself that you feel confident navigating the pelvis. Okay, so let's start here by talking about the 4 different types of pelvises. So in the upper left, we see a gynecoid pelvis, and that's essentially what we're hoping a woman has if we're trying to determine what type of pelvis she has. It's the most typical shape for women, and it's nice and roomy for the fetus at both the inlet and the outlet. So the image on the left are all the inlets for each pelvis type, and then in the bottom right, you can see the outlet. And that upper right is showing you the mid-pelvis for each of these different types of pelvis types. So the gynecoid is the roomiest. So about 50% of women have a gynecoid pelvis. And then you can see the next image there is an android pelvis. And that's what most men have. And about 20% of women have an android-shaped pelvis. So obviously women can still give birth with an android pelvis. It just tends to be a little bit squishier all the way through from inlet to outlet. And there's also the potential for babies to be a little bit more likely in an OP or occiput posterior position at birth. So that's when they're facing up instead of down, where the back of baby's head, the occiput, is towards the mother's posterior or sacrum. So occiput posterior. So then next up, we have an anthropoid pelvis, and you can see that the inlet is more oval shaped. So that AP diameter running from the sacrum to the pubic symphysis. So in all these images, you can see that the sacrum is towards the top of the image and the pubic symphysis is towards the bottom. So that is your AP diameter. So that's a little bit longer in an anthropoid pelvis, whereas the transverse diameter from one side of the ilium to the other, and also that would be where your 2 ischial spines are. That would be across the transverse diameter. So that's a little bit more narrow in an anthropoid pelvis. So it's right around 25% of women's pelvises are more anthropoid in shape. And then lastly, we have the platyploid pelvis. And that of the 4 is probably the trickiest one. So you can see that AP diameter is pretty narrow, and then it's the transverse diameter that's wider. The inlet itself doesn't tend to be as much of an issue as the outlet. So in that bottom right picture, you can see it looks like it would be fairly roomy with it being so wide, but it's that AP diameter that's really narrow. So that pubic arch is wide, but the AP diameter is narrow, and that's what can cause challenges. So those are our 4 pelvis types. And having a good sense of the bony landmarks at the inlet, mid-pelvis, and outlet can help you determine what type of pelvis type a woman has. So now let's talk through the mechanisms of labor. It's really worth committing these to memory because these are a favorite to show up on your board's exam. So in short, mechanisms of labor are just talking about how the baby moves and rotates and flexes in order to navigate the pelvis for birth. This list of steps here is consistent with an occiput anterior delivery, meaning that the back of baby's head is towards mom's pubic symphysis upon delivery, which is definitely the most common presentation. So first we have descent, meaning in order for the baby to come out, they're going to have to move down into the pelvis. So flexion is the next step, which really happens simultaneously with descent, but basically just saying that baby's going to flex their head. So the chin is tucking in towards their chest, and that's going to help give them the optimal fetal head diameter or circumference to help them navigate optimally. And then internal rotation is step 3. So initial engagement at the inlet happens in the transverse diameter. So the fetal head is in the transverse diameter. But then when they reach the ischial spines, we have internal rotation where the fetal head moves from being in the transverse diameter to the AP or anterior posterior diameter. So for example, the back of their head might be facing either the mom's right side or left side at that initial engagement. And then at the level of the ischial spines, internal rotation causes that head, in order to navigate the pelvis better, in order to have a better fit, that's the tightest spot. At that point, their head is going to rotate to have the back of their head be towards the pubic symphysis of mom. So at the inlet, it's a little bit easier to navigate transverse, and at the ischial spines in the mid-pelvis, it's a little bit easier to navigate in the AP diameter. Our next step is birth. So the fetal head has been flexed all the way down up to this point, and then at the time of birth, when the head emerges, it's birth by extension. So their chin's been tucked in, and at birth, they flex their head, moving the back of their head back towards their back, and that's how they emerge. So we know that at this point, the head is in the AP diameter, but the rest of the body is still in the transverse diameter from when they were first engaged in the pelvis. So we see this external rotation, also known as restitution, where the head turns to be transverse again to better align with the rest of their body. So it's born in the AP diameter by extension, and then it rotates so the back of the head either goes towards mom's left hip or mom's right hip, depending on how the rest of their body is aligned internally. So for example, if the fetus's back is on mom's left side, then when the baby comes out in the AP diameter, they'll shift so that the back of their head is also towards mom's left side. And then finally, expulsion is the rest of the body following the head being born. And that happens first with the anterior shoulder and then the posterior shoulder. So the anterior shoulder is the shoulder that would be lined up right by mom's pubic symphysis, and the posterior shoulder would be towards her sacrum. So if a mom were lying on her back, it would be the top shoulder and then the bottom shoulder. But I would encourage all of you to really be thinking about all of these terms, left, right, anterior, posterior, as it relates to mom's pelvis, because we check moms in all positions and we help catch babies in all positions. So if she's on hands and knees, that would mean that we're helping facilitate the birth of that bottom shoulder first and then the top shoulder. So anterior shoulder, posterior shoulder, regardless of what position she's in, that holds true. Now, if you have a primip or a first-time mom, it's very common to see each of these steps really clearly delineated. And then worth noting that if you do have a multip or a mom who's had other children before, this may all just happen and look like it's happening at once in one big birth, and you can't really distinguish the steps, and that's fine. So we know that the degree of flexion a fetal head has greatly impacts the diameter that it takes for that fetal head to be able to navigate the pelvis and ultimately emerge. So we refer to fetal head flexion as being attitude. So it'll be important to know these terms, and I think the easiest way to commit them to memory is to first learn the regions of a fetal head. So let's just start with the back of the baby's head. We call the back of the baby's head an occiput. And then if you were referring to the region just lower than the occiput, you can call that the subocciput region. And then if you go higher than the occiput region, we refer to that as being the vertex, so kind of the upper back region of the fetal head. And then right on top of the baby's head, we would call that the bregma. So if you purchased a fetal doll, I would recommend just writing on the doll's head in pen, this is the bregma region, this is the vertex region, this is the occiput. And then the frontal bone is right in the front of baby's head. So like the region of the eyebrows, we would refer to that area as being the frontal area. And then lastly, the chin we call the mentum. And then submento would be just below that, so under the chin. So now when we combine those terms, we can refer to the different regions that would be emerging first through the pelvis. And ultimately, what we're seeing here is that the more flexed the fetal head is, the more narrow a diameter for helping navigate the pelvis. So our most ideal position would be suboccipitobregmatic, also known as a vertex presentation. So suboccipito, meaning that line starts lower than where the occiput is. Bregmatic, meaning it goes to that top part of baby's head. So that leaves a vertex presentation being a well-flexed head for the suboccipitobregmatic. And that comes to about 9.5 centimeters in diameter. So you'll notice that the submentobregmatic, meaning under the chin up to the bregma or the top of baby's head, has the same diameter at 9.5 centimeters. And that's actually a face presentation, so really extended. So it's worth noting that the actual diameter isn't so bad with a face presentation, but the reason we're wanting a vertex presentation and not a face presentation, even though they are the same diameter, is because blood tends to rush to whatever part is presenting first. So if it is a face presentation, that can lead to a lot more facial bruising and potentially bruising in the airway as well, which can make recovery right after birth potentially more challenging. In addition, in order to be able to have a vaginal birth, you have to have a mentum anterior presentation, meaning the chin is towards mom's pubic symphysis for a face presentation, or the head isn't able to navigate the pelvis. So that's the other thing to think about if you do have a face presentation. So then this next line you can see here is the vertical mental presentation, and that's a brow presentation. So it'd be the brow coming down first, and that's actually 13.5 centimeters, so a pretty big difference from a 9.5 centimeter diameter emerging. So a brow presentation is basically the head is extended, whereas a face presentation is it's hyperextended. I remember a birth I had not that long ago at the birth center that was a brow presentation, and that mom pushed and pushed and pushed, and we just couldn't get that baby out and ultimately had to transfer. And now I can't remember if they ended up having a C-section or were able to have a vaginal birth, but it's hard. It's hard to get them out at 13.5 centimeters, and postpartum, that baby just had huge bruising right along their forehead, and it just made perfect sense that that was our challenge for that labor. And then lastly, we have occipitofrontal, so going from that frontal bone to the back of baby's head. And that's basically a military presentation, meaning it's not really flexed or extended. And that's at about 11 centimeters. So not ideal either, but certainly more manageable than a brow presentation. And lastly, I just wanted to point out the biparietal diameter, since that's the widest dimension for the fetal head. So that's going from one side of the parietal bone to the other side of the parietal bone. And as a fetal head navigates the maternal pelvis, the tightest place is going to be when that biparietal diameter hits the maternal ischial spines of her pelvis. Okay, so let's just look at fetal head dimensions from one other angle here. So in that upper left image, you see a vertex presentation or suboccipitobregmatic, and that's the 9.5 centimeter diameter. And in the upper right, you see that military position where it's approximately 11 to 12 centimeters. So that's our occipitofrontal presentation. And then in the bottom left, we have our brow presentation or vertical mental, and that's the one that's about 13.5 centimeters in diameter. And then lastly, in that bottom right, we have our face presentation, also known as submentobregmatic, and that's 9.5 centimeters. And again, if we're referring to flexion of the fetal head, we can call that attitude. So there's a flexed attitude or a military attitude, or what kind of attitude are you seeing? You're seeing it as a brow presentation. You might hear that terminology. So we can actually feel baby's head in labor to determine what position babies are in by feeling their fontanelles. So if the cervix is open enough, we can use the suture lines on the fetal head along with the fontanelles to be able to determine position. So this image is of the top of the fetal head. So you're putting 2 fingers in and you're feeling for that sagittal suture. You can see that suture that's running all along the top of the fetal head, dividing the parietal bones. And then you're feeling for a fontanelle. So you've got your suture, your sagittal suture, and then what you need to figure out is which side is the front of baby's head and which side is the back of baby's head based on where that line runs, right? So the anterior fontanelle is essentially shaped like a diamond. This diagram is calling it the anterior fontanelle bregma, but generally you'll just hear it called the anterior fontanelle. And then the posterior fontanelle is shaped more like a triangle. Generally speaking, if you're finding a fontanelle, it's going to be your posterior fontanelle. Feel that it's a triangle, not a diamond. And then you want to see which way it's pointing. I think of that triangle as being kind of like an arrow in that it's pointing in a way that continues to run down that sagittal suture line. So find your posterior fontanelle, you feel that it's pointing in a direction, and then if you follow that suture line, then that's going to be pointing towards the front of baby's head. You need to be able to identify where the back of baby's head is in relation to the maternal pelvis to determine what position the baby's in. So when we're determining positions, it would read like LOA or ROT. So that second letter is a fetal letter. So for the second letter, that's referring to what part of the fetus we're referencing. And you have 3 options. You have the occiput, which is whether we're vertex, brow, military, anything but a face presentation. If it's the head coming down, we're saying where is the occiput, or the back of baby's head. Our other options there would be a mentum if it's a face presentation, or the sacrum if it's breech. So if you do have a face presentation, you're not saying the back of baby's head, you're saying where is that chin? The mentum is that chin region, right? So where is that chin in relation to the maternal pelvis? And then sacrum, it's the back, baby's lower back. Where is baby's lower back in relation to the maternal pelvis? So all these images for this diagram are in relation to the occiput, which is going to be the vast majority of births, right? So vertex presentation. So that second letter is the O, and then the first letter is in reference to if the O or occiput is facing more towards mom's left side or right side. So in all these images, it's essentially got mom lying on her back for that first image where you're just seeing the fetal head presenting, or if she was standing up, that's the second image in each of those blocks. And again, if you're checking her on hands and knees, you're going to think of it in terms of the left side of mom's left hip or mom's right hip. You're not thinking of it in terms of up or down or left or right. It's mom's left, mom's right. If the baby is exactly face up or exactly face down, then you can just call that straight OA or straight OP, and you can just skip the first letter. And then the final letter is in reference to the maternal pelvis again. The occiput can either be facing anterior, meaning the back of baby's head is towards the maternal pubic symphysis, posterior, which means the back of baby's head is towards the maternal sacrum, or it can be transverse, meaning it's straight, either straight left or straight right. It's not veering towards the anterior or the posterior. So let's just take a look at what that would look like with one of these boxes. So in the upper left, we see we have LOA. And if you look at the fetal head on the left side, you can see that we have that anterior fontanelle in the bottom left corner, and we have the posterior fontanelle in that upper right corner. We can tell that's the posterior one because it's more like a triangle, and you can see that arrow pointing to the bottom left. So then when we know we've got our posterior fontanelle, that's going to be right by our occiput, right? So then for the maternal pelvis, we're looking at where is that occiput in relation to the maternal pelvis. It's more on her left side than her right side. Again, we're facing this pelvis. So it's not my right, my left. It's the maternal right, maternal left. So we have L as our first letter for the left side is where that occiput is. O is our second letter because we can do the occiput in contrast to having a face presentation or a breech. And then the final letter is going to be A because it's more towards her pubic symphysis than her sacrum. So that position is LOA. And then that picture on the right next to it, shows you that the back is along with the maternal left side, which goes right into the head being in line with that back. So the back of that head is a little more towards the front and facing mom's left side. That's the most common position. I think it's worth you taking your pelvis and your baby doll and really experimenting with this. Put the head in different positions, feel, okay, yep, that's where that posterior fontanelle would be, and be thinking through how that fits in relation to the pelvis. This takes a lot of kind of thinking and processing and getting used to how the fetal head navigates the pelvis in order to help this become an ingrained part of your practice. And now in this next side, that's again just showing you how the head would rotate and what that means for the different position letters, starting with LOA around 1 o'clock, going all the way to ROA around 11 o'clock. And again, the top and the bottom would just be OA and OP, or occiput anterior, occiput posterior. And then on that upper right side, you can see what it would be if you had a face presentation. Thinking about the difference between occiput presentations versus mentum presentations can mix people up a little bit because the mentum is towards the front of the face, whereas the occiput is the back of the face. So that the general position of the rest of the baby, it's going to look opposite for lettering when you're thinking about the back of the head versus the front of the head, or the chin in the case of the mentum. So where the back of the head might be towards mom's left side, if you have a face presentation, you're looking at where the chin is, not the back of the head. So it would actually be the right side in that case. So just be aware that those are going to seem a little bit reversed. And then in the bottom image, you can see how that would look for breech presentations. And then we're back to thinking about it. It's not the back of baby's head, but it is baby's back. You're looking at the sacrum. So what side is the sacrum is going to be what's going to align with the baby's back versus towards their genitals. All right, hope that helps. And then just a brief note on station for when you're doing cervical checks. You can see here how we'll start with -5, and then that goes down to 0, where the top of the baby's head is reaching the ischial spine. So that's 0 station there. And then +5, we're on our way out. But just to see that in light of the maternal pelvis. Your bony landmarks are those ischial spines, and you're feeling for the top of the fetal head, not the caput. You're disregarding caput, but where really is the top of the fetal head in terms of bony prominence moving forward, and at what point does that reach the point of the ischial spines. So I hope this was helpful in just bringing all the content together for you this week. And if you do have any questions, feel free to reach out. You can post those questions to the general forum where your peers can respond and faculty can respond. And I hope you all have a great week.